So in undergrad, I majored in operations research and financial engineering, partly because my dad said, be an engineer, it teaches you how to think. And it did. It was hard. But I loved the combination of math, but applying it to real life situations, problem solving. And then I actually minored in women and gender studies. So my classes were a really nice mix of genders. One was more male, one was more female in terms of like the number of women versus men in a class. But it was really interesting because when it came down to writing my thesis, because my undergraduate required a senior thesis, being a college student, was like, I want to write one thing. I don't want to have to do two for both of these focuses. And so I actually wrote my senior thesis on the HPV vaccine. And I looked at the impact of vaccinating 12-year-olds, if you were to vaccinate a cohort with that impact screening down the line. So I got to combine these math tools that I had learned and these analytic tools that I had learned, really like early data science, frankly, and machine learning before we called it that, before we called it AI, to healthcare. And I loved it. And it was great because I'd also been sitting in these classes in my undergraduate major thinking like, I want to apply this to something that isn't finance or baseball. And so like being able to apply to healthcare, I think really opened up a world of the potential of what I could do with my undergraduate degree. Post college, actually, my first job, despite all of that thesis, I'd actually already accepted a job at a bank. So I worked at Morgan Stanley for 2 years, and it was a great introduction to the working world and the business world, and training that you wouldn't really get elsewhere. But when the financial crisis happened, I kind of looked around. I was like, "Is this even really what I want to be doing?" And started to look into healthcare because I loved the idea that the economic model of healthcare was so imperfect and complicated, and you needed to think about people and people's behaviors, in addition to the just straight data on health. And there was just so much opportunity, I thought, because of how much data there was, but how frankly like not well we were using that data. And so, yeah, I went from Morgan Stanley, then I got a job at Greater New York Hospital Association. I was focused on managed care and actually spent a lot of time thinking about the impact the ACA would have on hospitals. So using a lot of my analytic tools, looking at enrollment numbers and impact on finances. And then from that role, I was like, I'm giving advice to hospitals I've never worked in one. I don't know what it really is like. And so then I moved to New York's Presbyterian Hospital, where I stayed for about 5 years. Started in the strategy department and then moved over the orthopedic service line. And really, part of that move was a focus on the hip and knee bundled payment initiative, which it was basically asking hospitals to take more responsibility for the cost of care once patients left the hospital after hip or knee replacement. And so, as part of that, the hospital got a ton of data from Medicare that they'd never gotten before. Data on where they were going post discharge, where they were readmitted, if they were readmitted. And that allowed us to make decisions and changes in how we delivered care that ended up resulting in better care for patients and reducing costs. And that was where my head was just like, this is where I want to be. I want to be thinking about how we can use data to make better decisions about delivering care. 5 years at New York Presbyterian, I loved it. I had a great experience. But I met my now husband, and we were ready to leave the New York City area. And when I was looking for my next job, two people pointed me towards Socially Determined and the work that Socially Determined was doing, because everything I talked about wanting to combine and do just made sense for me to look at Socially Determined. And so now 7 years later, I am still socially determined. So it was a good call. Those two people were right. And it's just for me, a really nice way of combining my interest in data, the value I see in using data to make decisions, and the real life messiness of real people and their lives, and how we have to think about real people's circumstances when we make decisions and when we think about how to deliver care to people and how to make sure that they are receiving the right level of care at the right time for the best health outcomes.